Hello and welcome to the February edition of ISGyP Live Journal Club. I'm your host and moderator, Karen Talia, broadcasting live from Melbourne, Australia. Joining me on the panel today from the ISGyP Live team is Dr. Natalie Benet. Our topic for this month is endometrium, and we have two pathology trainees and a gynae pathology fellow presenting. Next slide, please, Natalie. I'll start with some general information about Journal Club and forthcoming ISGyP Live programming first. As regular audience members know, Journal Club now alternates between the USA and Australia month by month, with Dr. Benet and I hosting the Western and Eastern Hemisphere sessions respectively. Next slide. And here is the schedule for the remaining sessions for 2022. I'm pleased to say there's been a lot of interest in Journal Club, and I'm almost fully booked for participants for the remainder of the year, but I still have some vacancies for the November gynae cytology session. So if you want to join us as a presenter, please get in touch via email. I'll list the email addresses in a moment. Next slide, please. So here's our learning objectives. Our main objective with Journal Club is to engage junior and trainee pathologists in critically evaluating the literature and honing their presentation skills. We'll provide you with a journal article and offer written feedback on your presentation, including a practice session online so that you can build confidence presenting using this digital format. Next slide. We'll also give you a PowerPoint template for putting your presentation together, and this is a summary of that template which steps you through how to present and appraise an article. Next slide. If your preference is for case-based learning, please also consider the Interesting Case presentation series moderated by Dr. Jennifer Bennett. And this runs to a similar format as Journal Club with 3 presentations per session and mentorship in the lead up to the day. So for both of these events, you don't need to be an ISGyP member to participate, and also a reminder that ISGyP membership is free to trainees. And to attend Journal Club as an audience member or any of the ISGyP Live educational events, you can register via the ISGyP educational website, isgyp.ca. And as I'm sure you know by now, you'll be sent a reminder ahead of the session and a video link afterwards to watch the recording if you missed out on the live event. And also recordings of Journal Club are posted to YouTube. Next slide. In terms of upcoming events, there is lighter scheduling in March due to the USCAP meeting, and you may have noticed a few slides back that we will be taking a break from Journal Club in March. We do have 2 more events on the calendar for February. Dr. Bennett is presenting the Interesting Case presentation session on February 23rd at 8 AM US Eastern, and digital slides can be previewed prior to this session. Next slide. There's also an upcoming podcast titled Evaluation of Endometriosis in Peritoneal Biopsies by Dr. Jacqueline Watkins, hosted by Dr. Carlos Parra-Haran. And this episode goes live on the same day, February the 23rd at 12 o'clock US Eastern on the ISGyP Live SoundCloud page. Next slide. Finally, before we get started, this is an interactive session, and if you'd like to ask questions as we go along, please post these using the Q&A button. You can also use the chat function to tell us what part of the world you are joining us from and give our speakers some encouragement along the way. Also, at the end of the presentation, an evaluation survey will open up, and we would appreciate you taking time to fill this out. Okay, so next slide is our schedule for today. This month's theme is endometrium, and we've got 3 papers dealing with aspects of one of the most commonly encountered tumours in gynae pathology practice, low-grade endometrioid adenocarcinoma. We've got, first of all, Dr. Sara Diab from Australia presenting a paper on endometrial adenocarcinomas with no specific molecular profile. And then Dr. Priyanka Yadav from India presenting a paper looking at diagnostic accuracy and assessing depth of myoinvasion in low-grade endometrioid carcinomas. And finally, Dr. Lucy Han from the USA is presenting a paper on corded and hyalinized and spindled endometrial carcinoma. Next slide. So now I'm really pleased to introduce our 3 speakers. Dr. Sara Diab is a final year trainee in Melbourne, Australia, working at Australian Clinical Labs. Dr. Priyanka Yadav is a 2nd year pathology trainee from Kasturba Medical College in Manipal, India. And Dr. Lucy Han is a fellow in GYN pathology at Stanford University, United States. All right, so let's get on with our first presentation. Sara, when you're ready, if you could share your screen and unmute yourself. I'll turn off my camera and I'll I'll mute myself as well, and you're good to go.
Yes, so can you see my screen now?
Yes, I can see your screen and we can hear you. Thank you.
Okay, thank you. Hello, everyone. Thank you for joining this afternoon. Thank you, Dr. Karen Talia, for this opportunity. My name is Sara Diab. I'm an AP trainee at Australian Clinical Labs in Melbourne, Victoria. The title article is Endometrial Adenocarcinoma with no specific molecular profile, morphologic feature, and molecular alterations of copy number low tumors. This article was written by Dr. Vivienne Meljen and Dr. Kylie Strickland and other co-authors from Duke University Medical Center and Cancer Institute. So the background that endometrial adenocarcinoma have been classified previously, basically depending on morphology. So type 1 tumors with low-grade endometrioid morphology, FIGO grade 1 and 2, and type 2 tumors with high-risk histology, including serous, clear cell carcinosarcoma, and grade 3 endometrioid tumors. However, this classification shows some drawbacks as proportion of patients with low-grade and early-stage disease recur, cannot be cured with radiation or chemotherapy, and have poor outcome. So the molecular classification came out from the Cancer Genome Atlas Network, which identified 4 molecularly classified subgroups of endometrial adenocarcinoma that correlated with progression-free survival. These groups are DNA polymerase epsilon mutated, microsatellite unstable hypermutated, copy number high, and copy number low tumors. Copy number low category is a diagnosis of exclusion as it shows overlapping features with the other groups and lack a specific molecular identifier. However, about half of the copy number low tumor harbor CT and NB1 mutations, and these tumors show poor prognosis even in the low-grade endometrial adenocarcinomas, especially in young age. So the aim of this study is studying this copy number low group to determine more common specific molecular aberrations, describe its morphologic appearance, and determine the utility of beta-catenin immunohistochemistry as a good surrogate marker for CT and NB1 mutations. So the study composed of 19 in-house cases with copy number low endometrial adenocarcinomas, and the cases were evaluated according to morphologic pattern mutational profiles, which were documented and correlated with the tumor morphology and beta-catenin immunohistochemistry. So the clinical data was retrieved for the 19 cases, which included 14 tumors with whole genome sequencing performed and 5 tumors from patients with advanced or recurrent disease who had also next generation sequencing performed. All available slides with tumor were examined for each case, and the morphologic pattern were categorized by 2 anatomical pathologists into squamous differentiation, even if it's focal less than 1%, mucinous differentiation, also even if it's focal, and endometrioid morphology exclusively. Mutations in CT and NB1, ESR1, KRAS, PIK3CA, and P10 genes were correlated with the tumor morphology. Ancillary studies was performed, and immunohistochemistry staining for beta-catenin was considered positive if 1% or more of the tumor cell nuclei stained strongly. Then pathological review was performed. 19 digital slides of the copy number low tumors previously identified by TCGA were reviewed blindly by 4 pathologists, and the morphology was correlated with the mutation status. One thing to mention here that the pathology review of these 90 TCGA cases was performed separately to the 19 in-house cases. And the aim is to further validate the previous observation and to determine the agreement on squamous differentiation or mucinous differentiation. Statistical analysis was performed. Fisher exact test was used to analyze categorical variables and SLIS-kappa for assessment of agreement. So table 1 here shows the patient demographic. Median age at diagnosis was about 60 years. And stage 1 was present in about 2/3 of cases, and no cases show stage 4. About quarter of the cases show lymphovascular invasion, and about half of the cases show recurrent disease. Copy number low tumors with squamous differentiation was present in 47% of the tumors, which was strongly associated with CT and NB1 mutations, 8 out of 9 cases. Beta-catenin was positive in these cases, and none of these tumors had KRAS mutation. And here the tumor shows squamous differentiation and demonstrated nuclear positivity for beta-catenin by immunohistochemistry. Molecular characteristic of this type of tumor with squamous differentiation is presented here in table 2, and most of the tumor harbored CT and NB1 mutation. Copy number low tumor with mucinous differentiation was present in 3 cases, and all the cases harbored KRAS mutations. It was significant, this correlation between mucinous differentiation and KRAS mutation was significant in in-house cases. However, it wasn't significant in the review of digital images from the TCGA. Here the tumors show mucinous differentiation, and it shows only membranous staining for beta-catenin by immunostains. And table 3 shows the molecular characteristic of this tumor with mucinous differentiation, and all the tumors harbored KRAS mutation. The last category is the copy number low tumor lacking both mucinous and squamous differentiation, and this was present in 7 cases. Only 4 cases harbored the CT and NB1 mutation, and out of these 4 cases, only 2 cases express beta-catenin. And here we can see the exclusive endometrioid morphology, which demonstrate membranous staining for beta-catenin by immunohistochemistry. And table 4 show the molecular characteristic of this tumor with exclusive endometrioid morphology, and about half of the cases harbored CT and NB1 mutation. Then morphological review shows strong agreement for squamous differentiation. However, there was weak agreement for mucinous differentiation. Out of 15 cases, 13 cases showed identical interpretations. However, 2 cases were discordant and overcalled on digital images. So copy number low tumor is the most common type of endometrial adenocarcinoma, but have no specific molecular profile. It has several distinct morphology that are associated with specific molecular subtypes. Squamous differentiation was present in 47% of tumors, and it is enriched for CT and NB1 mutations, which demonstrated nuclear positivity for beta-catenin by immunostains. Mucinous differentiation was enriched for KRAS mutation, and endometrioid morphology, 57% harbored CT and NB1 mutations. This study and previous study confirmed the utility of the identification of CT and NB1 mutations in copy number low tumors. These mutations are associated with poor prognosis, but in a clinical trial, an improved outcome in this tumor, which harbor the CT and NB1 mutations when treated with bevacizumab. Immunohistochemistry, of course, is an attractive surrogate to molecular studies as it saves resources. Beta-catenin is a sensitive and a specific marker for CT and NB1 mutations, and it was often positive in areas of squamous differentiation. For that reason, pathologists should choose blocks containing areas of squamous differentiation when selecting tissue for staining in order to reduce false negative results. Next, KRAS mutations are commonly associated with a variety of the tumors in the female genital tract, and here it is associated with copy number low endometrial adenocarcinoma with mucinous differentiation. A digital review showed that mucinous differentiation was over-interpreted, and the morphologic criteria for mucinous differentiation was defined here. including the avoidance of interpreting extracellular mucin as definite evidence of mismatched differentiation. Interestingly, 2 tumors in the TCGA cohort demonstrated mutations in both KRAS and CTNNB1, one of which demonstrated prominent squamous metaplasia. Another thing to mention that a subset of copy number low tumors harbor concurrent mutations in CTNNB1 and ESR1. This is the gene encoding estrogen receptor alpha. This mutation may have significant clinical implications in the future. So to sum up, this flow chart shows that there was 19 cases of copy number low tumors. These were the in-house cases. Out of these 19 cases, 9 cases show squamous differentiation. And out of these 9 cases, 8 cases harbored CTNNB1 mutation, in which all of these cases show nuclear positivity for beta-catenin. Mismatched differentiation was present in 3 cases, and all of these 3 cases harbored KRAS mutations. And the exclusive endometrioid morphology was present in 7 cases. Only 4 cases show CTNNB1 mutation, and half of these cases only show nuclear beta-catenin staining. So the strength of this study is that the objective of the study and the inclusion and exclusion criteria were specified. Study selection was described, and flow chart was presented. Digital slides from the TCGA databases were reviewed by other pathologists blindly, and p-values provided in some cases and in other cases mentioned as significant or not significant. And finally, the mismatched differentiation morphologic criteria was identified. Areas for improvement is that the study was generalizability limited, as the study was limited only to cases which had molecular profiling performed, either via TCGA or due to disease recurrence, which means that they selected out a recurrent case to some extent. The morphologic review of the TCGA digital images was limited, since only representative slides were available from the online database. And future studies should investigate the functional significance and the consequences of mutations in KRAS, ESR1, and PIK3CA. And the application of this study, that maybe we need to start to practice using beta-catenin immunohistochemistry in the routine cases of endometrial adenocarcinoma, as this can predict the prognosis. Thank you, and I'm happy to take any questions.
Thank you, Sara. Just before we move on to the polling question, we do have one question that perhaps we'll address now from Dr. Carlos Paraharan. Carlos's question is, in carcinomas with squamous differentiation, was the beta-catenin nuclear expression restricted to the squamous component, or was it seen in the glands as well?
Yeah. Actually, some of the tumors show positivity in the glands, and some of the tumor was strongly positive only in the squamous area. So that's why, yeah. So that's why they came out at the end with the conclusion that they should choose better squamous differentiated areas. Also, 2 tumors which didn't show squamous differentiation and didn't show beta-catenin at all, it was negative. So that's why squamous differentiation is correlated with beta-catenin expression.
Thanks, Sara. I also saw that question pop up and just reread the results section of the paper. And for the tumors with squamous differentiation, I can't see that they actually specify where that focal staining was, and it often was focal. But interestingly, in the digital image or the photograph of the photomicrographs of the stain, the beta-catenin stain in the tumours with squamous differentiation, which I think you showed in one of your slides. The beta-catenin staining is both in the squamous component and very focally also in the glandular component, although much of the glandular component looks negative. So I don't know if that answers your question, Carlos. I think the staining was present potentially in both components. Well, I think we've got a pretty good result.
Okay, I'll go ahead and end the poll and share the results for everyone to see.
We've had nine respondents and pretty much perfect score. So question 1, which of the following is true about endometrial adenocarcinomas with no specific molecular profile? And the answer is C. These copy number low tumours with squamous differentiation are enriched for CTNNB1 mutation, although the mutation is also seen in tumours lacking squamous differentiation, as we were discussing, but it may be harder to detect that positive beta-catenin stain in those tumours. And answers A, B, and D are wrong for obvious reasons. I hope this was an obvious answer. The copy number low tumours are the largest group in percentage terms with the TCGA classifier. The prognosis varies, and we think that CTNNB1 mutation helps determine those patients that have a poor outcome. And the inter-observer agreement for the presence of mucinous differentiation wasn't strong, it was poor. And I think this reflects in part the over-interpretation of the presence of extracellular mucin as definitional for mucinous differentiation. We really need to see cytoplasmic mucin to declare something as mucinous in differentiation. And then regarding the beta-catenin immunohistochemistry, all of these statements are true. It's a sensitive and specific surrogate for the mutation. Strong nuclear staining in 1% or more of cells is considered a positive, and ideally select blocks containing squamous differentiation to increase the sensitivity of the stain. Fantastic, thank you. So now let's move on to our next presentation. So Priyanka, when you're ready, if you'd like to share your screen.
Hello everyone. I'm second year pathology department resident in Kasturba Medical College. I'll be presenting the journal on the topic diagnostic accuracy in assessment of depth of myometrial invasion in low-grade endometrioid carcinoma. It's a 2-center comparative study by MRI and intraoperative assessment. It was published in the International Journal of Gynecological Pathology, September 2021. And the author is Rebecca Nagar et al. So for the treatment of endometrial carcinoma, the treatment protocol hysterectomy is done with bilateral self-finger oophorectomy along with pelvic and para-aortic nodal dissection. But this treatment is still controversial in cases where the role of nodal dissection comes in caution. And most of the time it's in the patient who have low-grade endometrioid carcinoma cases. Because only in less than 10% of these patients, nodal metastasis has been observed. So, but in nodal metastasis is increased in the patient who have the deeper myometrial invasion compared to the patient who have only superficial myometrial invasion. In superficial myometrial invasion, it is seen to be about only 5%. It increases to 20% in patients who have deep myometrial invasion. So a risk factor that contribute to the lymph node metastasis include tumor type, grade, and the presence of lymphovascular invasion and deep myometrial invasion. So the aim of this study is to compare the diagnostic accuracy on the MRI and to compare it where the MRI is used in most of the European countries, and it's compared with the intraoperative assessment that's done in US. So myometrial invasion is assessed preoperatively by MRI in the European countries, and in US the intraoperative assessment is by the gross examination. Either we're doing on alone on gross itself or in conjugation with the histological frozen section analysis is done in the cases. Previously also many studies and many articles have been done in this case where many cases were taken and many articles have already published. But instead of going with all of the studies, majority of these articles were single institution studies, and it was difficult to ascertain whether the findings. So multiple studies have already been done where they compared the MRI and the intraoperative assessment findings. But majority of these studies, they were single institution study, and the inclusion and exclusion criteria were not defined properly. And it might vary based on these studies, whether it was difficult to ascertain whether the finding truly reflect any diagnostic expertise, or it's secondary to the variation in the diagnostic modality that were used in these studies. So the method used in this journal are all women who were diagnosed with endometrial cancer who underwent hysterectomy between 2013 and 2018 at the Belfast Cancer Center in Belfast and UK, and from 2003 to 2012 at the Beth Israel Deacon's Medical Center, Boston, USA. They formed the initial study group in the study, and the exclusion criteria that were women having high-grade endometrial carcinomas, women with extrauterine disease at the surgery, patient in Belfast who did not have an MRI that was older, more than 30 days before the hysterectomy was done in the patient, and the patient with extrauterine disease on preoperative MRI. These patients were excluded. So in Belfast, the cases were taken who had endometrial carcinoma, and they were discussed pre and post operatively at Northern Ireland Gynecology Oncology Multidisciplinary Team, and MRI was done on 1.5 Tesla scanner. In Boston, patients underwent hysterectomy for endometrial carcinoma were evaluated intraoperatively for deep myometrial invasion. Gross assessment was done for deepest myometrial invasion, and representative sections were given for frozen section. And findings were reported as less than 50% or more than or equal to 50% myometrial invasion. So data analysis and statistical analysis were carried out to allocate the calculation of sensitivity, specificity, positive predictive value, negative predictive value, positive likelihood ratio, and negative likelihood ratio. In these stats, positive predictive value and negative predictive values, these are affected by the disease prevalence. As in the study, two different study cohort groups are being compared. So the authors have taken in consideration the likelihood ratio also. Likelihood ratio, it isn't affected by the disease prevalence. So it compared to the negative and positive predictive value, it's a better parameter when we comparing the performance of the two diagnostic modality in the two separate cohort study groups. This table in result shows the demographic and clinical data of the two study group in Belfast and Boston. In the Belfast group, age ranging is 64.1. In the Boston also it's 1662. And lymphovascular space invasion in hysterectomy specimen is seen more in the Belfast group, and the higher grade, more cases with the higher Figo stage on hysterectomy was seen also in the Belfast group compared to the Boston group. And in this result, here first the 95% confidence interval, only these states were taken into consideration, because here the confidence interval represent the range of scores that are likely, if we were repeat the survey again, maybe it give us the same result. So 95 confidence intervals. So the result that the authors have gotten is significant. So I'll be covering it in two steps. First, I'll be comparing the MRI findings of Belfast and with the combined intraoperative assessment and frozen section. Here the sensitivity in MRI is 72.84%, whereas it is 78.26% in the combined assessment. And the positive likelihood ratio was 6.59 in MRI in Belfast, and it's 20 in the combined assessment of IOA and frozen section. And when we compare positive predictive value, it came out. So in the result, the authors found that in MRI, when we compared it with the combined IOA and frozen section, sensitivity was 72.84% in MRI, and it was 78.26% when the combined assessment was done. The likelihood ratio was 6.59 in MRI, and in Boston it was 20. And positive predictive value was 75.64% for the MRI was done, and 80 for the Boston group of patients. But when we compare the gross only intraoperative assessment in the Boston for the only gross assessment, and we compare it with the combined intraoperative assessment and frozen section, the sensitivity and positive likelihood ratio and the positive predictive values were found to be lower in the intraoperative assessment group was done, and it was found to be more when combined intraoperative assessment and frozen section was done. So based on these results, the intraoperative assessment when is done with frozen section was superior to the MRI in detecting deep myometrial invasion. So in the discussion part, the authors have discussed the intraoperative assessment with frozen section was superior to MRI in detecting the deep myometrial invasion, and the gross assessment alone was fairly close with the specificity of 95.9% and a positive likelihood ratio of 18.6%, as when we compare it with the combined IOA with specificity and likelihood ratio of 96 and 20 respectively. The advantages of a frozen section include that on frozen section we can diagnose the high-grade endometrial carcinomas also during surgery, and objective evaluation of tumor that grossly exhibit myometrial invasion, but the distinction between the inner and outer half involvement cannot be made with the certainty on the cross examination alone. But in frozen section we can assess it accurately. So the reasons why there was discrepancy between the MRI and intraoperative assessment, because in few of the cases there might be presence of fibroid of adenomyosis, which will make the MRI and IOA assessment difficult. And when the neoplasm present as a diffusely infiltrative neoplasm, where small dunks of small clusters of neoplastic cells are present, then they exhibit a microcystic, elongated and fragmented pattern of myometrial invasion that will extend beyond the main tumor mass, and it show a diffuse infiltrative pattern. So because of that diffuse infiltrating pattern, it won't elicit a stromal response that's observed in the MRI. So advantages of preoperative MRI additionally included, it can give us clinical important information such as uterine size, cervical invasion, and to identify any enlarged lymph nodes. So any prior studies that have done on the assessment, they reported a certain range. On the intraoperative assessment, sensitivity showed 64 to 93%. In MRI, the sensitivity was 50 to 87%. Specificity on intraoperative consultation was 90 to 99%, and on MRI, it was 86 to 91%. Positive predictive value range was 71 to 93% in intraoperative consultation, and in MRI, it is 7 to 95%. So in prior studies, we got a range. So these range and these differences in different studies, it might be because the inclusion criteria may be different from one study to another, and what available diagnostic expertise they used there. And the variation in the MRI data can also be partly accountable based on what resources were available there and the technical differences in the imagining methods. So one of the study that was a one institution study, Tanaka et al., they studied 378 patients and they compared the use of MRI and intraoperative assessment, but they included all the histological types and grades of endometrial carcinoma in their study. Their sensitivity, specificity, and the positive predictive value, negative predictive value on MRI was lower compared to these value on the frozen section that was done. In this study, the authors have taken in consideration only low-grade endometrioid carcinoma, and in this study we have shown a better sensitivity for both MRI 72.8% and intraoperative assessment of 78.2%. But slightly lower positive predictive value for the intraoperative assessment by the author is 80% is likely because in many of the cases only intraoperative assessment was limited to the cross examination only. frozen section was only done based on the decision taken at the time of the operation. So in conclusion, the road of nodal dissection is still controversial in the low-grade endometrial carcinomas. Previously, authors have observed two randomized controlled trial where the trials failed to show any overall survival benefit from a full nodal dissection. And there's been still argument that the sentinel node biopsy could be reserved for women who are having low-grade endometrial carcinoma and deep myometrial invasion on the MRI. And there was failure. If failure is there to find the sentinel node, currently it leads to the full pelvic nodal dissection for the patients. And conversely, we could do that all women could be offered a sentinel node biopsy. But if this fails, then a full pelvic nodal dissection could be offered only if the intraoperative assessment suggested a deep myometrial invasion. So based on these conclusions, to look forward, so how do we manage the patient? Do we increase the use of sentinel node biopsy? And in sentinel node biopsy, the procedure, cyan in green dye is used to highlight the sentinel node pelvic nodes, but on failure, we are not able to detect the sentinel node, a full pelvic nodal dissection is done. Or we increasing, because increasing use of sentinel node biopsy, in case where there's a failure to find the sentinel node, then a full pelvic nodal dissection could be offered. Only if the intraoperative assessment suggested deep myometrial invasion. So we do a full nodal dissection only when we get a deep myometrial invasion. But for that, the most important factor that we need to consider are the cost and available resources, and whether the patients there in that region, whether they can afford it or not, and whether these facilities are available to them or not when choosing the method of assessing the deep myometrial invasion, and whether it would work best for a specific patient population. So to confirm this thing, we need further studies are needed to create specific guideline to when to do the sentinel lymph node biopsies. The strength and the weaknesses of the study. The strength, as a relatively large patient cohort was taken in consideration, and in the weakness, two different populations were compared, and the study period of the two cohort was also different. And MRI contrast was not used in the Belfast population. Normally in MRI, we use the gadolinium contrast that is specific for detecting more of superficial myometrial invasion rather than the deep myometrial invasion. Thank you for listening.
All right. Hello, everyone. Thank you so much for. Thank you. Thank you so much for having me here today. My name is Lucy Hahn. I'm one of the GYN pathology fellows from Stanford. And today I'm going to be talking about the corded and hyalinized and spindled endometrioid endometrial carcinomas by authors Safdar and colleagues. Endometrioid adenocarcinomas comprise approximately 80% of endometrial carcinomas, and they demonstrate morphologic heterogeneity. The corded and hyalinized endometrioid carcinoma, or CHEC, and endometrioid carcinoma with spindle cells, or also known as ECS, and they frequently occur in the ovary, are rare variants of endometrioid adenocarcinoma. Both of these lesions are biphasic neoplasms, and therefore the main differential diagnostic consideration here is carcinosarcoma. However, the former, so CHEC and ECS, are associated with well-differentiated adenocarcinomas, and they typically have good prognosis, whereas carcinosarcoma is a high-grade neoplasm and is associated with poor prognosis. The TCGA subclassifies endometrial carcinomas into four prognostically significant molecular subgroups. And so the objective of this paper is to evaluate the clinical pathologic findings, immunohistochemical features, and polymutational status of both CHEC and ECS. Additionally, the authors aim to classify CHEC and ECS according to the TCGA molecular subgroup. CHEC classically is characterized by having a low-grade glandular component, which is blended with a corded and hyalinized area. And these areas can demonstrate myxoid or chondroid change. Classically, we think of these corded areas to have minimal cytologic atypia, And mitotic activities can be seen, although they're rare. We see areas of squamous differentiation with keratin pearls, and we can also see areas of osteoid production. This is an image of ECS arising from the endometrium, but it looks morphologically similar in the ovary. Here we can see a spindle cell component which merges imperceptibly with the glandular component, and both of these areas have low-grade morphology. The spindle cell component can form diffuse sheets, nests, they can form concentric whorls, or they can have interlacing fascicles. As I mentioned, CHEK and ECS are biphasic neoplasms, and therefore the main differential diagnosis is carcinosarcoma. But CHEK and ECS is associated with well-differentiated adenocarcinomas, and both the glandular as well as the chordate or the spindle cell component is morphologically low grade. In contrast, carcinosarcoma is defined as having spatially distinct carcinomatous and sarcomatous component, and it portends to a poor prognosis. The TCGA subclassifies endometrial carcinomas into these four different subgroups. There is the POL-E ultra-mutated pathogenic group, MMR deficient group, P53 mutant group, and no specific molecular profile. The aim of this paper is to subclassify ECS and CHEK into one of these particular subtypes. The authors selected their cases based on the consultation files of the authors and included 7 hysterectomy specimens and 2 endometrial curettage specimens. Immunohistochemical stains were performed on all cases, including P53, 2-panel mismatch repair protein, and beta-catenin. P53 was classified as aberrant if there was either complete absence of staining, greater than 80% nuclear staining, or cytoplasmic expression. And beta-catenin was classified as abnormal if there was nuclear expression. POL-E mutational testing was performed on all cases via Sanger sequencing. Overall, there were 9 cases that were included in this study, including 7 cases of CHEK and 2 cases of ECS. The average age at diagnosis is 49 years old. Overall, there was a wide variety of different stages at presentation. However, most of the tumors had low grade. The exception is case 1, which presented at FIGO grade 2 to 3. And this tumor also had extensive lymphovascular invasion. Among the tumors, there was a difference in the proportion of the glandular component compared to the chordate or the spindle cell component, but almost all of the cases had squamous differentiation. There was limited clinical outcome data, and it was available for 3 patients. Patient 3 had no evidence of disease at 18 months. Patient 7 had no evidence of disease at 7 months, and a 3rd patient died of other causes at 3 months. Figure 1 highlights a conventional CHEK. On low power, in one of the cases, we can see nodular architecture. And on higher power, we can see cords of epithelial cells, which is embedded in this hyalinized stroma. And we can also see areas of squamous differentiation. Some of the tumors demonstrated areas of myxoid change. And when beta-catenin was performed, it demonstrated nuclear expression in both the chordate as well as the glandular components. Case 1 was a case of a higher grade CHEK. It was, as you may recall, a FIGO grade 2 to 3. And then this tumor, the chordate area had increased mitotic activity as well as apoptosis. And we see extensive LVI here. P53 was performed in this case, and it was normal in both the chordate component as well as the glands. And beta-catenin demonstrated nuclear expression. There were 2 cases of ECS. In both of those cases, there was a low-grade spindle cell component, which is arranged in fascicles and merges with the well-differentiated adenocarcinoma component. Focally, there was some papillary formation and mitotic activity could be seen. Beta-catenin staining demonstrates nuclear expression in both the spindle cells as well as the glands. Table 2 highlights the immunohistochemical profile as well as the Puechl mutational status of CHEK and ECS. As I'd mentioned, there are 7 cases of CHEK and 2 cases of ECS. P53 was wild type in almost all of the cases except for case 5, which had an aberrant overexpression of P53. Beta-catenin was nuclear in almost all of the cases except for case 8 that demonstrated normal membranous staining. Mismatch repair proteins were intact for all of the cases, and no Puechl mutations were identified in any of the cases. There was additional immunohistochemical stains performed on case 1. Pancytokeratin showed strong diffuse staining in the glands, but it was negative in the corded component. And Paxate was positive in both the glands as well as the corded component. Going back to case 5, this is the case with the aberrant expression of P53, and this is morphologically what this case looked like. Here we can see a corded component with background hyalinized material, and it's adjacent to a well-differentiated adenocarcinoma. And on the panel on your right, we can see this aberrant expression of P53. Because of the biphasic morphology, the differential diagnosis between CHEK and ECS is carcinosarcoma. CHEK and ECS overall have a good prognosis, although some studies have demonstrated that they may behave aggressively. These tumors tend to occur in younger patients than those in carcinosarcoma. And classically, ECS and CHEK are associated with low-grade endometrioid adenocarcinomas, and they typically present at low-grade and low stage. Morphologically, we can see a merging of the glandular, corded, and spindled components, and we don't see high-grade cytologic atypia in most cases. We can see areas of osseous metaplasia, which may be a point of confusion with heterologous differentiation with carcinosarcoma. And by immunohistochemical stains, we can see normal P53 and nuclear beta-catenin. However, as we saw in case 5, there are some CHEKs which may have aberrant expressed P53. Generally, keratins are positive in the glands, and we tend to lose some of that expression in the corded component. And classically, we can see a CT-NNB1 exon 3 mutation, which correlates with the beta-catenin gene. In contrast, carcinosarcomas are aggressive neoplasms, and they demonstrate poor prognosis. These tumors tend to occur in postmenopausal women and often present at high stage. These tumors are classified as having spatially distinct high-grade carcinomatous and sarcomatous components, and we can see heterologous differentiation in these tumors, most classically rhabdomyosarcoma. By immunohistochemical stains, we typically think of carcinosarcomas as having abnormal P53 and normal beta-catenin. However, cases of carcinosarcoma have demonstrated nuclear beta-catenin as well. In keratins, in terms of keratin staining, there tends to be limited expression in the sarcomatous component. And correlating with the abnormal P53 immunohistochemical stain, we can frequently identify TP53 mutations among others. So based on the TCGA molecular classification, approximately 10% of tumors, endometrial carcinomas, fall under this Puechl ultramutated pathogenic group. These tumors tend to have ambiguous morphology and show prominent tumor infiltrating lymphocytes, but these patients typically do much better. On the other side of the spectrum, we have P53 mutant tumors, which are associated with poor prognosis. With an intermediate prognosis, we have about 30% of tumors that fall under the MMR deficient category, and the remaining fall under this no specific molecular profile category. Recent articles have demonstrated that perhaps beta-catenin could be used as an additional marker in order to subclassify these patients that fall under the no specific molecular profile category. Based on these studies, approximately 19 to 37% of tumors fall under the beta-catenin abnormal category, and these tend to have a slightly worse prognosis than beta-catenin normal tumors. So based on this TCGA molecular classification, CHEK and ECS tends to fall under this no specific molecular profile category, whereas carcinosarcomas fall under the P53 mutant category. So in conclusion, CHEK and ECS are usually low grade and low stage, but they may behave aggressively on some instances. It's incredibly crucial to distinguish CHEK from carcinosarcoma due to the differences in prognosis. And based on the TCGA endometrial carcinoma classification, none of the tumors demonstrated any POLE mutation. On rare occasions, there was P53 mutation. However, this category most classically falls with carcinosarcoma. None of the tumors demonstrated any microsatellite instability. So most of these tumors fall under the copy number low or no specific molecular profile subgroup. And recent studies have demonstrated that tumors with a beta-catenin gene mutation may have a slightly worse prognosis. And so there are many strengths to this paper, including that this is a very unique study that's evaluating the molecular landscape of CHEK. And this paper included a relatively large number of cases given how rare the entities are. And it's very important to risk stratify these patients with endometrial cancers and to place CHEK and ECS into a category. In terms of limitations of this study, there was limited long-term clinical follow-up for these patients. And for me, I'm interested to know the CHEK case with aberrant P53 expression. How did that patient do in the long run? Did the patient have poor prognosis or did the patient do well? So in this paper brought up some questions that unresolved questions that I had that potentially could be the topic of future studies. The first question that I had is, does beta-catenin abnormality represent a good or sort of more of an intermediate or poor prognosis? And the reason I ask that is if beta-catenin abnormality portends to a worse prognosis compared to wild type, then how do we explain the seemingly contradictory statement that CHEK tumors have a good prognosis? And the second question that I had is, in certain cases, there seems to be an aggressive CHEK. And what's the difference between those cases versus carcinosarcoma? How do we reliably differentiate them? Are we able to differentiate them by molecular technologies, or are we able to differentiate them by immunohistochemical stains or perhaps morphology? And in terms of prognosis, is there a difference between these aggressive CHEKs and carcinosarcoma? So I will stop there. Thank you for having me. I'm happy to take any questions.
Fantastic, Lucy. That was a brilliant presentation. Much appreciated. We've got some polling questions. We don't have any audience questions at this stage. I'll let Natalie go ahead and launch the poll. Okay, so here are our answers, and we've got a little bit of a mixed response for both questions, which may reflect my complicated wording of the question more than the audience's knowledge. So which of the following is true of CHEK and spindled endometrioid carcinomas? And the correct answer is that CHEK tumours usually show low-grade cytomorphology, squamous differentiation, and may demonstrate bony metaplasia. All of those are features of CHEK neoplasms. The chordate and hyalinized and spindled elements are not abruptly demarcated from the glandular component. There's usually a merging of the two components, which is one of the points of distinction with carcinosarcoma. And for grading purposes, we grade purely on the glandular component and disregard the spindle component and not consider that a solid tumour component. And everyone got this one correct. Most of these tumours cluster to the copy number low, not the copy number high molecular subgroup. And with respect to the immunohistochemical findings for these tumours, which of the following is not true? And the answer is B, mutation type P53 staining is common. That's not true. Only 1 out of 9 cases in this series had mutation type P53 staining. It's usually wild type. I think we've also got a spread of answers across A and D as well. So A, in this cohort, CHEK and spindled endometrial carcinoma commonly express nuclear beta-catenin. That is true. And this is where the wording is crucial. The question is asking which is not true. And answer C is also true. Cytokeratin staining in the cord and hyalinized component is variable, and although it may be positive, it's often weaker and patchy compared to the glandular component. All right, well done, everybody. We've run over the hour, unfortunately, so we'll wrap up there now for today. I think it's been a really interesting session, and as a laboratory that doesn't routinely perform beta-catenin, I'm certainly going to be thinking about that every time I see squamous differentiation or the occasional check pattern tumour. Not that I've had many of those. And lots of unanswered questions as well, particularly in that spectrum of so-called aggressive or high-grade check with carcinosarcoma. It'd be really interesting to see that dilemma resolved as time goes on. Thank you to our fantastic presenters. You all did a brilliant job in spite of technical glitches and difficulties. Thank you, Priyanka. As I said earlier, there won't be a journal club for March, so we'll be back on in April. Thank you, Carlos. He's giving everyone congratulations on some great presentations. Thank you to our audience, and we'll look forward to seeing you next time.